Welcome to the Pain Pod. Hey, I'm Dr. Ham. I'm with Dr. Dan Kim from Indiana Spine Group. Thank you for taking the time to join us.
Well, thanks very much for inviting me. I'm excited.
I think the goal of this podcast is to kind of get your perspective in terms of from a surgery perspective, in terms of your approach to pain, and we can kind of compare and contrast kind of our approaches and whatnot. But first, tell me about yourself, or tell the audience about yourself.
Yeah, well, I've been in Indiana my whole life. I went to school here. I trained here at Indiana University. And I went into the specialty of neurosurgery. And the past, 3 or 4 years, I've been with the Indiana Spine Group and have specialized in spine. Before that, I was in a general practice where 20% of my practice was cranial, but now 100% of my practice is spine related. So obviously, our fields overlap quite a bit with regard to complex pain issues and spine issues.
Yeah. Okay. Cool. Tell everybody a fun fact about yourself.
You know how God gives you a talent, and everyone thinks, well, with a doctor, it must be, God gave you the talent to take care of people. And I think that's true. I believe that. But I really feel like if society had made it an important thing, I would be very famous today for the crab walk. Because I feel like when I was a kid, I was so good at the crab walk. Do you know what the crab walk is? You ever do the crab walk?
Yeah, you mean like in gym class, like when you're young, or is it a dance?
No, I can't dance. It was amazing how much better I was than the other kids. And I feel like that was my real talent.
I get that. That's cool. Well, thanks for sharing that. My talent, I would say, is I collect sneakers. So, sneaker check today.
Oh, those are nice.
Got the Supreme Jordan 5s from 2014. What was I doing at the time? I was on my phone waiting for like hours, just tapping buttons, trying to get sneakers.
Your whole life?
Not my whole life, but a significant portion. Like, I've probably lost days of my life doing it.
Yeah. Are like Jordans like your favorite shoe?
I'd say so. Or at least I'm a big basketball fan. Although I grew up watching LeBron.
Yeah, you're from Cleveland.
Yeah, so that's where I grew up. I did my medical school training there through Northeast Ohio Medical University, which was like a 6-year program. And it's like the public medical school of Ohio. I did my residency in anesthesiology at Case Western Reserve University Hospitals. And then I did my pain management training at the University of Cincinnati. And then I ended up here, just next door in Indiana. Yeah. And I've been loving it so far.
I think for your viewers, like in the medical field, we understand this, but for the viewer's background, I'm sure Dr. Ham is being very humble. To do a 6-year program where you combine college and medical school is super competitive, very difficult to do.
I appreciate that. I try to tell my mom that, but my mom doesn't listen to me. My mom's like, oh, whatever.
Don't play the violin, so it doesn't count.
I think this is like a nice opportunity to, it's not often that in pain management I get to sit down with a surgeon one-on-one to talk. But what would you say, like, from your perspective, or how do you approach patients with spine and complex spine issues, and how do you think that compares and contrasts to the way we in pain management does that?
Well, obviously we come at it from different perspectives, different cultures. We read different books and literature. But I think, especially with your group, I feel like we have very, very common goals. And our goal always is to try to treat patients' pain issues in the most conservative way possible. So from that perspective, diagnosis is key, trying to figure out where the pain is coming from so that we come up with a comprehensive plan. And I've always said that you can't get into the thought pattern of everything is the same and everything has the same solution. And so just because I'm a surgeon doesn't mean the solution is always surgery. I think that's a very dangerous philosophy to have in medicine. And so I think from that perspective, I think you and I are very similar. We try to take the patient as an individual, figure out what's going on, and then figure out what we can do in the least invasive way to try to treat them. And a lot of times it does come down to surgery, but hopefully that's the last resort.
Yeah, I think I agree with you. I totally agree with you. I think in terms of the way I approach things, it's always patient first. Like I'm always talking to the patient about what's your function like, what's your goals like, and that's the most important thing. We always rely heavily on like diagnostic imaging and stuff, but I tell patients like, hey, I treat patients, not imaging. So sometimes patients, they have like pain, but or they have something on the imaging that's not symptomatic or whatnot. So that's where the art kind of comes in, where we don't always have to intervene just because there's something on the MRI.
Yeah, absolutely. I agree with that. And I think a lot of our patients get confused because they'll get an MRI and they'll get a radiology report that says just a litany of things that are wrong with them. And we have to counsel them and tell them, no, actually, those things are a normal part of the aging process. And a lot of those things they're incidental in the meaning that we only caught them because we took a picture. They're not really the cause of your problem. And a lot of my patients, they need a lot of coaching and encouragement to realize, no, actually your MRI looks okay. Let's focus on your symptoms, like you said, and try to figure out what's going on.
Yeah, absolutely. I think there's definitely a lot of overlap in what we do, and briefly in terms of what I do as an interventional pain doc, in terms of things that I can offer, would be I tell everybody like, hey, from a conservative standpoint, you start with like non-invasive physical therapy. There's some conservative medications, that we could try and stuff. We do rely heavily, I think, as pain medicine, we rely heavily on diagnostic injections and other types of injections to help symptomatic treatment. And then there's now like a growing field of minimally invasive spine procedures, as well as like stimulation and those kind of things. Can you talk a little bit more about some of the things that you can offer to patients? Obviously, maybe the different types of surgery and kind of what the indications might be.
Yeah, absolutely. So if you've exhausted all of your treatments and it comes to the point where we have to consider doing something more invasive to change the structure of the spine to try to alleviate pain, then that's where surgery comes into play. And my practice is pretty broad. I will do minimally invasive surgeries. I'll do open surgeries. Some surgeries are decompressions only, where we take off bone and ligament, maybe to get access to a herniated disc to remove. That can be done in an outpatient setting. To the other end of the spectrum, where we're doing a very large, complex spine surgery that includes decompression, but also includes deformity correction, instrumentation and fusion, which means putting in screws and rods or plates to augment the spine. Yeah. So kind of run the whole spectrum of whatever that particular patient needs. And like we were talking before, every patient is individual. We don't operate on MRIs or radiographs. We operate on the person, and we operate for their symptoms.
Yeah, absolutely. And I think like some of the ways that patients maybe might not recognize how much we collaborate, but oftentimes like we're concurrently working people up together, or like I'll do an injection, report back to you, or they'll go back to you. And kind of report back into what you're saying. That kind of guides you. So basically the information I get, helps you. The information you get helps me.
I think with your group and with you in particular, our communication is great. I think we know each other. We have each other's cell phone, and I think that's always helpful. I'm a big proponent in communication. I think 2 doctors are better than 1. I think 10 doctors are better than 2. And I think we're all on a team to try to treat somebody, and people are very, very complex, and the more we're talking, the better. You can tell me, hey Dan, I did this C6 selected nerve root block and it didn't help, and then I can say, okay, I'm not going to do a big surgery on this person because it's not going to help, and otherwise I'm in the dark and I just take a shot and then I have a failed surgery. So it's always it's always good to communicate. I think, again, with your office, it's been great.
In terms of like, you're at the forefront of spine surgery. What are some new advancements going on, or are there any new advancements going on that can help patients?
Yeah, the field is always evolving. We're always pushing ourselves to try to figure out better, more efficient, safer ways to do things. In my group, we're fortunate to have a fellowship program, which means we train young spine surgeons that want to specialize in this field. And by doing that, we have to stay current. We have to stay on top of all that technology. Over the past 10 years, I think the big pushes in surgery have been different approaches to taking care of spine problems. When I trained, everything was posterior with regard to the lumbar spine. We all did posterior surgeries, and we still do. It's a workhorse. It works well. But now we're learning how to do some anterior approaches beyond, the traditional ALIF. We call it the anterior lumbar interbody fusion. Now we're doing lateral surgeries, oblique surgeries, one position surgeries, and then we're melding that with navigation, which is kind of an intraoperative GPS system that's come about in the past 20 years. Robotics is coming into play. I'd say the newest development that people are looking into in our group is just starting to look into it is endoscopic spine surgery, and it's very big in Asia, and we're learning from our Asian colleagues on how to do it safely and when it makes sense to do it. A lot of these technologies you have to be careful. It's good to learn to understand what's available, but a lot of these technologies, it's safer to do it the old way. It's quicker to do it the old way, and the people that are pushing the frontier are trying to figure out how to make it work for a surgery that works very well. So in those cases, you got to weigh the benefits of the new technology for sure. It could be, with regard specifically to endoscopic surgery, it might be a good technique to add for somebody who's really young and has a big disc herniation that can be easily taken out through a very, very small incision. The advantage of endoscopic surgery would be less disruption to the tissues, the muscle, the bone, the ligament, but it comes at the cost of not seeing very much, not having access to the things you would like to have access to. And again, we've got a surgery that works very, very well for that. So we're just learning what's the best approach, and learning all of it, that's the key. Yeah. And then you can say, this is going to work, and this is probably not ideal, and we've got another technique to deal with the problem.
Yeah. Disc, now that you mentioned disc pathology, I think that disc pathology, herniations and stuff, they're one of the hardest, or just disc pain itself, discogenic pain. It's kind of, there's not a lot of options to treat from my standpoint. What is your take on like disc-related pain, disc herniations? Do you think that they typically, in your opinion, like resolve on their own, typically over time, or at what point would you say, hey, somebody needs surgery?
Yeah, no, I think that's a great question, and a question our patients have all the time, because they come in with an acute disc herniation. It's been going on for a week. They're miserable. There's just no light at the end of the tunnel for them. We can tell you, we can reassure patients that, we've been studying this for a long, long time. We've done natural history studies, and the vast majority of people that have a disc herniation will get better without any intervention at all. It's just a matter of time. And during that time, the question is, can you control the symptom severity enough so that people can wait it out for their bodies to kind of take care of the problem? And that's where we really heavily rely on interventionalists to give a very significant reduction of pain. It might not be forever, but if we can buy a month, 6 weeks, that might be enough. By the time your steroid injection wears off, a lot of times the inflammation that's causing all the symptoms goes away. So we heavily rely on that. When the symptoms have been going on for more than 6 weeks, or if they're worsening, if they're not having a progression to healing, then I'll talk to patients about surgery. Because what we don't want to do is allow that nerve root that's irritated and symptomatic to continue on for a number of months to the point where there's permanent damage. And as a surgeon, all I can do is pluck out the disc herniation. All I can do is decompress the nerve. The nerve has to heal, and if we allow it to go on too long, there is a risk of permanent damage. But with lumbar disc pathology, you've got months and months to safely wait, and that's where other conservative management, epidural steroid injections, and things like that really help out.
Do you think disc herniations are preventable, or do you think that they're just...
No, I don't. I think they're very random. They can be traumatic, but the vast majority of disc herniations just happen because of genetics. Whatever your parents gave you with regard to your genes. We know the pathophysiology of disc herniations. There's a very thick layer, the annulus fibrosus, that kind of the radial belted layer around the softer nucleus, sometimes tears, and it usually tears, unfortunately, where the posterior longitudinal ligament isn't reinforcing the annulus, and that is just in the wrong spot, and it goes back and it pinches a nerve root, and that just happens, and most of the time it's random.
Okay. What about... I commonly get people who say, "Oh, I have degenerative disc disease." In terms of like disc spacers or replacements, do those? What's the data on that like?
For axial back pain, which means predominantly back pain and not leg pain, it's ironic because you think back surgery would help back pain, but I tell my patients all the time, back surgery usually doesn't help back pain. What we are doing with surgery is we're relieving pressure on the nerve roots, and those nerve roots go down your legs and not to your back, at least the big ones that we're operating on. And so when you have degenerative disc disease and a lot of bone spurs and a lot of degeneration on your MRI, it can be a generator for pain, axial back pain, but surgery is usually the wrong route, because we can make the pictures look nice, but we can't take away the back pain for the most part. And that's where I'm excited to ask you your opinion with some of the emerging technologies that you're involved with, what you can do for that problem.
For like disc-related pain?
Yeah, for like, let's say you've sent me a patient with back pain with no leg pain. They've got degenerative disc disease. They want a surgical opinion. I tell them, the good news is your MRI, it looks good. I don't see any surgical pathology, but the bad news is that I can't offer you any surgery because there's no surgery that's going to help this. At that point, a lot of times I'll give you a call and say, hey, Dr. Hom, can you consider taking care of this patient with interventional modalities to try to treat the symptoms of their pain?
Yeah. I think, axial back pain is like, really challenging to treat, and you have to really tease out what it could be. We had a lot of treatments before, like doing routine like discograms, and this was before my era of practicing pain. But I think there's been talk about like stem cells. There's been disc injections of other types, of like to try and rehydrate the disc. But unfortunately, the data hasn't been super good, and there's also that risk of discitis. So it's not routinely covered by insurance. I think disc pain is really challenging. And there's also this controversy of whether or not disc pain, or whether the innervation like really causes true axial pain or not. There is, for people with like modic changes, which means degeneration of the vertebral body and disc, there's something called the intercept procedure, or it's basically there's like nerves in your vertebral bodies, and we can go in and ablate those, assuming you don't have like osteoporosis and stuff, no structural problems, and that can sometimes help people with preaxial pain. So that's kind of an exciting emerging therapy that's going on. Otherwise, for axial back pain, we often lean into like the facet injections, which is the medial branch blocks and the ablations, those kind of things. And then otherwise epidurals. And yeah, that makes it really challenging. And then I think intrathecal pumps and stims are getting better at treating those kind of axial back pains as well. So that's been a nice like rescue therapy as well.
Yeah, absolutely. I mean, as a surgeon, I lean heavily into that, at least as an option to discuss with a doctor, with a patient that has failed everything else. I've had patients I've tried to help with surgery, and unfortunately they just haven't gotten to a point where they're happy. And that's what I'll call you and ask if there's anything else that you can offer. And I feel like patients have a lot of encouragement and hope. And you do help a lot of my patients with those modalities. I think it's very important, and I try to coach my patients when I send them to you, that this isn't a cure. This isn't going to make them feel like they're 20 again. But it is something that is very low risk, and it provides a lot of significant relief. I often tell my patients, these problems are not life-threatening, but they're life-robbing for sure. And it's depressing to wake up every day with this pain. I think any decrement of that pain intensity that we as doctors can give is helpful. And so I do think that intrathecal pain pumps and spinal cord stimulators are a great modality to help a lot of these folks with just chronic pain.
Yeah. Hey, and I appreciate you, also, I think education's a huge part of it. I don't like to, I prefer to undersell and,
Yeah, over deliver, absolutely.
over-deliver.
Yeah.
So,
Yeah.
before we wrap up, what would you say is the most rewarding part of your work?
Oh, absolutely, the patients. I mean, just being able to help somebody who's suffering. I think that's the reason most of us go into healthcare, and it's certainly a privilege to be in the office or the operating room and do something to make somebody's life better.
Yeah, absolutely. Yeah. For me, I would say definitely just seeing somebody's quality of life be able to improve, being able to hear back from them to say like, hey, I can lift my grandkid up, or I can spend more time with my family, or do hobbies I enjoy. Definitely is the most rewarding part for me. Now we're gonna close this with some fun questions. Dr. Kim, you're Korean. What's your favorite Korean food?
Boy, I'd say right now it's probably pork. I just got back from a trip to Korea. I hadn't been in like 30 years. And the first time, well, not the first time, that time I went, the last time I went, pork wasn't a huge thing. It was more beef. And beef was a special treat. It was pretty rare. But now Korea has developed quite a bit in the past 30 years, and they've imported and grown just tons and tons of pork. And so pork is huge, and it's like everywhere. And so you go to these restaurants where they bring you've probably been to a Korean barbecue place, but like they have like a live fire, and they bring you raw meat and you cook it there. And my favorite these days is the pork. And it's just like, it's essentially like bacon, uncured bacon. So you're just eating slices of bacon with rice and little side dishes. But that's definitely, it's probably not great for you, but it's definitely one of my favorites.
Yeah, I would say my favorite Korean barbecue would be the beef short rib. What do you think is the best Korean food in Indiana?
Mama's house.
Where's that at?
Oh, not my mama's. I mean, I guess I should say that. My mom doesn't watch this, but it's a restaurant called Mama's House.
Oh.
Actually, I think they changed the name. They used to be called Mama's House, but I think it confused people, so it's called Mama's Restaurant. And it's on Pendleton Pike and Post. It's been there for, I don't know, 40 years.
Okay, cool.
Yeah.
Well,
check it out.
If Mama's House, if you hear this,
hook
please
me up with some
sponsor
pork.
us.
Yeah.
Or we'll do a mukbang
Oh, yeah.
where we eat and talk in the same time.
Yeah, maybe the next time we
Next
do
time.
this podcast, we could do, we could do that.
How do people contact you if they want to schedule an appointment?
Oh, yeah. We have a pretty good footprint on the web, Indiana Spine Group. If you Google us, you'll get to our webpage, and it's pretty easy to navigate. I have a small team, and if your listeners want to write down my number, it's 317-428-5785. 5058, and you'll get Kendra, my scheduler. She's fantastic. And so I practice at multiple sites throughout kind of central Indiana. I have offices in Marion, Indiana, Kokomo, and Carmel, and kind of go all over the place to operate.
Well, you know, from my personal experience, I'd say my patients who have referred to you, they love you. You have great patient rapport. You care about patients genuinely, and couldn't recommend anybody else more than you. So.
Well, I feel the same way. Likewise. Yeah.